and I'm here to walk you through the hottest topics in stress, coping, and resilience. Now, some of these slides and topics we've kind of already reviewed in previous chapters, but I mean, it's kind of difficult, like I said before, to kind of separate these topics into discrete, or for our statistical heads out there, orthogonal topics, because all these factors in psychology are interrelated. So a few of these slides will be a little redundant, but they fit within the structure of this chapter. I've actually thought about creating and teaching an entire course on this exact topic because I've spent 5 years in my doctoral program, while being a PhD student, researching this topic and working in a stress lab. But for the purposes of this class, let's reduce that ambition to approximately 50 slides. All right, so with that said, let's jump right into it. Beginning with the mechanisms or mechanics of stress. Hans Selye, we'll go with, The Stress of Life, revealed decades of research on the effects of prolonged stress on the body. Humans are equipped with a sensitive physiology that responds to stress by kicking our bodies into high gear, leads to physiological and psychological breakdowns. The pattern of response to stress, Selye described, is called the General Adaptation Syndrome, GAS, and there are 3 stages of adaptation. So this dude is kind of like a famous stress researcher, thought kind of to be one of the OGs of kind of stress research. Again, kind of proposing how stress works and what are the lifelong developmental consequences of different kinds of stress. And as stated, there are 3 stages of adaptation to stress that occurs at a biological level. The first, the alarm reaction. The autonomic nervous system is activated, stress hormones are released, physical symptoms of anxiety appear. This is thought to relate to the fight or flight reflex. The HPA axis, the hypothalamus pituitary adrenaline axis, it stands for, biologically adapts you to stress. The hypothalamus, H, receives signal for fear, releases a hormone that binds to neuroreceptors in the pituitary gland. P, pituitary gland, releases a hormone which binds to receptors in the adrenal cortex. The adrenal cortex releases cortisol, which is a stress hormone. Slow stress hormones stay in the body for hours. So we have this HPA system is kind of our big takeaway here, wherein stress responses are received and then a series of biochemical reactions occur with the hypothalamus receiving that fear and then releasing a hormone. I'm not going to get into specific hormones, which then signals the pituitary gland to release another hormone, and then finally the adrenal cortex releases cortisol, which you would be most likely to be familiar with. And this is typically thought to be kind of a stress hormone. It's also important to note that cortisol alone isn't like this super universal negative stress hormone. It's also required. Some level of cortisol is required, or without getting into some sub-variations of like cortisol. Some cortisol is required during prenatal development. It's kind of like it acts as kind of like a growth factor. Or a growth hormone that allows a developing fetus to grow. But kind of here in the, you can imagine in the presence of excessive cortisol, that can be negative, it can have a negative impact on adults, on children, and also on a developing fetus, which can be associated with being born low birth weight or possibly other long-term biological consequences. There's a whole study of research called Developmental Origins of Disease Theory. You're not tested on this. That basically just argues that these kind of stress hormones in pregnancy is linked to long-term health outcomes. So, but the big takeaway here, we have HPA axis, which kind of is one mechanism by which stress hormones are released in the human body. All right, so following that initial alarm reaction, we've encountered a stressor, something dangerous or something that is stressful to us. We have this kind of fight or flight kind of reflex. And then next, after that initial alarm, we have resistance. So after initial rush of stress, hormones, the conscious decision-making, quote, the thinking brain, the cerebral cortex, you adapt and find ways to cope with the stressor. And then exhaustion. In prolonged stressors, months, our resistance can break down, can cause physical or psychological damage. So we have that initial response, then we kind of have this resistance wherein we're kind of, okay, what do I do about this right now? How do I adapt? How do I cope with the stressor? And exhaustion, wherein kind of you see kind of a decrease in the amount of stress hormones such as cortisol. But in the presence of like prolonged stressors, that don't go away, and you're kind of like always kind of hypothetically, theoretically speaking, kind of always in that fight or flight mode, that can contribute to kind of a breakdown of biological processes, which can contribute to behavioral changes and negative outcomes, developmental outcomes across the board. And this can accumulate. And as stated, this is kind of one of the earliest theories to demonstrate a link between psychological reactions and physical illness. Reaction to distress was the cause of physical illness, as Selye found. So we kind of have this theoretical model of stress hormones increasing, which are valuable. You gotta either run away, you have to fight, or whatever. Kind of basic kind of theoretical evolution kind of stuff. And then kind of like a come down period. But in the presence of chronic stressors, that come down period may the amount of cortisol release getting back to that equilibrium. Some people either do not ever reach that equilibrium again, or actually, interestingly, instead of that initial alarm reaction, one effect of chronic stress could be that there isn't that initial reaction at the same level as a person who's not exposed to chronic stress. So they're kind of numb to the pain kind of thing. So you have kind of two different variations of possible responses to chronic stress. You have that numb initial pain, and or also have the kind of continuously elevated amount of cortisol. So basically never returning back to homeostasis. That is that stage 3 exhaustion phase. Again, never returning to the baseline amount of cortisol. And those that either elevated baseline cortisol, that initial non-reaction to the stressor, or interestingly, another possibility is that an elevated reaction to the stressor, so going above like the normal curve. So you have all these kind of different possible biological outcomes associated with chronic stress, which theoretically, and studies have demonstrated, are correlated with certain behavioral outcomes and also certain psychological disorders, such as externalizing disorders or internalizing disorders. So that's kind of like the framework here. Some theories of stress, and I'm just kind of largely sticking with the book. This book's kind of some of these theories. There's different wordings depending on the scientist, but without making it super complicated, we're kind of sticking to the terms of the book. So theories of stress. Reaction to acute stress is an adaptive mechanism, response-oriented viewpoint. Explanations of stress that focus on the physiological reactions within an individual. Stress hormones like cortisol. Life-changing events. Events that alter the trajectory of an individual life. These life-changing events can accumulate stress and can lead to different stress reactions. One way to measure this is ask a series of questions about the amount of stress one experienced in their life, and then kind of add up the total amount of stressors, and then kind of do correlations / more rigorous statistics in that. But kind of an easy way to think about it than do a correlation is this total raw number of accumulated stressors as measured in this checklist kind of thing, correlated with internalizing behaviors. And stimulus-oriented viewpoint, explanation of stress or focus on the stressors themselves, the stimuli or life events that trigger the stress reactions. So this is kind of like looking at the specific events, so a hurricane, a war, a recession, COVID, something along those lines. And that's I've done primarily my research on on that stimulus-oriented viewpoint. I've worked in a biological lab, but primarily I've kind of looked at the stimulus-oriented viewpoint. So kind of the idea here is looking at stress, looking at these huge life events, and then seeing if they're related to certain developmental outcomes. And then kind of review quickly again, response-oriented viewpoint is really looking at the responses within the individual. You can measure cortisol, for example. What my lab did was collect hair samples from mothers in the Democratic Republic of the Congo, and hair actually can be used to measure cortisol. You can measure cortisol through blood. You can do it through saliva, and basically, depending on the method in which you're the method of biological collection has different. Actually, well, simply stated, cortisol stays in certain parts of your body longer than others. So if you're looking, hair is kind of thought to be one measure of like chronic stress, and cortisol and saliva is thought to kind of have a shorter kind of lifespan, or the amount of cortisol circulating in saliva is thought to be shorter than hair. So kind of the point here is, though, you can measure these physiological responses, cortisol level, cortisol amounts within hair, saliva, blood. And you can also look at it at a genetic level as well. So correlating like the amount of cortisol and the amount of XYZ genetic expression, for example. And then you can also correlate that with exposure to certain life events and stressors, and do all these complicated statistical things. So that, again, that's the main takeaway here is that you can look at the stimulus itself, or you can look at the physiological response within an individual. All right, some types of stress: short-term life events, definitive beginning and end; chronic life strain, stressors that are continuous and ongoing. Some argue they are the most predictive of later life negative developmental outcomes. Work stress. Workers face high demands but have a good amount of control and sense of personal accomplishment. Work strain. Workers face high demands but no control, no sense of personal accomplishments, low reward. Major life events: divorce or death of a loved one. Daily stressors: the routine challenges of day-to-day living. Your laptop key gets broken, arguments with children, caring for the elderly parent, balancing roles in your life between being a spouse, parent, and worker. Some argue that the accumulation of daily stressors can accumulate and contribute to negative developmental outcomes. Most common type of daily stressor, according to a 2005 study, was interpersonal. All right, so let's recap some of this. So we have short-term, so some of these definitions are kind of straightforward here. We have short-term stress, kind of a beginning and end. You have daily stressors, but hey, I got to send this damn email, and then I'll send this email, and then it's done. I can move on with my life. Kind of short-term, kind of annoying, but you move on with your life. Chronic life stress, much different. It's continuous, ongoing. Maybe exposure to poverty, racism, kind of overall disenfranchisement, maybe a bad relationship that you're stuck in. So this can be interpersonal and also kind of those macro, and of course those types of stressors interact with each other dynamically to kind of form kind of a global chronic life strain. An interesting one also is kind of neighborhood noise. And kind of crowding, neighborhood crowding is also associated with kind of negative developmental outcomes. And when we have worker stress, worker strain, you can kind of see the difference here. And this is a classic kind of thing of stress research, which argues that basically high demands with little control, little sense of kind of personal fulfillment, and low kind of financial rewards, but also social rewards, interpersonal rewards, kind of being valued as like a worker. In that case, that combination of high demand, low control, little payment, little social respect, little prestige, contributing to higher worker strain, and thus which is correlated with negative developmental outcomes. And then we have those major life events: divorce and death of a loved one. But also, it's important to keep in mind the age of when the stress happens, and we'll talk about different kind of interpretations of stress. But the age of when a stressor occurs, it's different to lose your spouse at 20 years old versus 100 years old. And then we have these daily stressors, which can be a little more mundane, but also less mundane. So caring for an elderly parent, for example, and obviously balancing the roles of parent, spouse, workers, it can be quite difficult. And again, the idea here, the accumulation of those stressors contributing to negative developmental outcomes. And here we will reintroduce allostatic load, with the argument kind of being here that the more lifetime factors, that is chronic stress, the more at risk a person is for negative developmental outcomes. With all these risk factors related here: class, nutrition, race, substance abuse, stress, infections. Allostatic load is the cumulative wear and tear on the body's systems owing to repeated adaptation to stressors, which is thought to contribute to cellular aging, clinical health diagnosis, and telomere length. Allostatic load is calculated by summing the scores on various biological outcomes such as blood pressure, total cholesterol, C-reactive protein is a very common one. And so kind of the idea here is that, again, you kind of do a little checklist here of all the stressors that someone experiences, and then you have this other kind of, so you have like this stressor checklist of, did you experience this today? Did you experience this today? Or have you experienced this chronically for the last year? Or something along those lines. And then also you have this cumulative allostatic load measurement, which basically what they're doing is kind of very something similar. There's different ways to calculate it, and the simplest way to think about this is not exactly correct, but say someone's high blood pressure, so you have a number, X number, that's like average blood pressure, and then anything above that is like you're at risk, so that person would get a check mark there, so that would count against them. So the higher that number is, the higher your allostatic load. So basically they have all these cutoffs for all these biological measures. You then add up all the numbers, add up all the checks, and then you can do statistical analysis based on that. And the idea here is that through time, this chronic stress contributes to, and we've already talked about in previous chapters, possibly cellular aging, telomere length, which is again kind of a genetic marker of chronic stress and thought to be correlated with physical health outcomes. And I want to bring in just a recent study, actually, allostatic load and its impact on health, a systematic review, 2021 study. Systematic review, you can kind of conceptualize them as a meta-analysis, basically kind of gathering other people's empirical studies and then kind of doing statistical analysis on it, and then coming to like a conclusion based on like the totality of that data. So basically combining all those studies' data into one massive database and then doing stats on them. So here, so you should be kind of familiar with this, and you can see now how improvement in like reading a scientific literacy has happened through this course. So you can see here, their objective is to summarize the current knowledge of allostatic load. They looked at a total of 267 original investigations. That is, original investigations, they're referring to empirical studies. And the conclusions are that the findings indicate that allostatic load and overload are correlated with poorer health outcomes. So that's a positive correlation. The higher the allostatic load, the higher the risk is for poor developmental outcomes. The assessment of allostatic load provides support to the understanding of psychosocial determinants of health and lifestyle medicine. An integrated approach that includes both biological markers and clinometric criteria is recommended. Doesn't matter. So kind of the idea here is what we've already talked about, that we have these psychosocial determinants of health, this accumulation of stress being correlated and acting as a risk factor for negative developmental outcomes. And actually, when I was at the University of Florida, we worked with their big hospital that's located very close to campus, pretty well known. And they were kind of beginning or trying to improve the amount of kind of stressors collected. So trying to, came to us kind of to work with us on research, but also kind of improve kind of clinical practices, collecting data on stress, for example, and then using that as another measure, basically, of overall health and well-being in a patient. And also, it wasn't my research, but a colleague of mine was who worked with them. They would mothers who recently gave birth would to basically sign off on allowing the. So my colleague would work with doctors to do scientific analysis on the or medical doctors to do scientific analysis on placenta. So there's basically a whole kind of research into like placenta, the impact of like chronic stress on placenta development, and maybe the size of placentas being infected by chronic stress, which then impacts a developing fetus, which again, going back to that developmental origins of disease theory, impacts the different sizes or kind of parameters of the placenta being thought to be correlated with organ development, and some various neurological development is occurring rapidly as a fetus, and thus possibly linked to various long-term developmental outcomes. Again, not tested on in this class, but kind of that's some interesting background information, hopefully. Effects of stress. Early studies show a significant relationship between self-rated life change events and a number of health problems. Stress causes increases in unhealthy behaviors, such as tobacco and alcohol use and overeating. Intercorrelated nature of developmental factors, certain common factors such as poverty, cause both a high number of stressors and poor health. So kind of the idea here, speaking to the intercorrelated nature of all these developmental processes, that not only stressors can accumulate kind of on a biological level, but also you have to deal with those stressors, right? So how do you deal with those stressors? Well, a lot of stress is correlated with unhealthy coping habits. So drug abuse, for example, eating unhealthy foods, because it's like, well, I have to deal with this, I have to feel better, so I'm going to engage in these activities, which can have negative outcomes, or associated with negative developmental outcomes. And kind of that accumulation of stress, negative coping strategies, or I mean just coping strategies in general, contributing to poor long-term health outcomes across adulthood. And then in poor neighborhoods, not only that, but you have all these other, environmental levels of adversity within your environment, and also kind of like less access to resources in the community that can act as resilience. We're going to kind of a prelude another slide, but basically community resources can act as resilient factors or sources of resiliency, protective factors that buffer the impacts of stress. So you can imagine for like a kid, maybe a park or a gym to play basketball in, or a library, or something along those lines. So that combination of community level protective factors not being present, while also stressors are present, then also you have unhealthy coping habits, all these combining to contribute and put people at risk of negative developmental outcomes. So kind of as stated, one way of measuring stress is by calculating the number of major life events over the past year an individual has experienced, and that's specifically looking at the Social Readjustment Rating Scale, the SRRS. It ranks a number of particular stressful events, and those events, again, is kind of the number of major life events over the past year, and it's has been found to be related to physical and psychological health. This kind of measure, or this specific measure treats stress as a stimuli. There are 43 life events which are ranked: jail time, medical illness, being fired from work, associated with physical and psychological disorders. However, it neglects coping resources or chronic issues. So kind of the idea here is you're presented with a list of 43 life events, and you just check them off. However, what they do is they do something called weighting the events. So basically, each event that's checked is not worth the same amount of points. So some going to jail or something, or witnessing murder, would be ranked more points than having a controllable medical illness, for example. So again, but the idea here is that you add up this cumulative score, and then you do statistics on it and see if it's correlated with stuff. And research has found that it is indeed correlated with developmental outcomes, physical and psychological outcomes. However, it's important to keep in mind that this is not calculating kind of the role of chronic stress within an individual. So what is the duration of time that an individual is experiencing those 43 life events? Instead, it's kind of treating it as a yes or no dichotomous question. which again, strength and weaknesses for all these measures, but that's kind of a limitation of this measurement. And it's also not calculating the access to coping resources, the protective factors within a community, a country, a neighborhood, or within a family, social support within an extended family, for example. Another way to look at stress is this hassles, minor annoyances that strain our ability to cope. Hassle scale, 117 items. Some of the items include losing things, being exposed to traffic jams, how many arguments you have, how often you're disappointed, your weight, how you rate your physical appearance. The number of hassles is positively related to illnesses, depression, and anxiety. Frequency and perceived severity of hassles, overreaction to minor stressful events predict long-term anxiety and depression. Depression, anxiety, and physical health. Research shows this is true even when major life events are controlled for. So kind of the idea here was before we had these major life events, you win this murder, you went to jail, you have this chronic illness, you're fired from work, you lose all your income. Here we kind of have more of these minor inconveniences, traffic jams, losing things, interpersonal arguments. And the idea here is that, again, you kind of add up all these daily hassles and then do some stats. Now, interestingly, and if you remember from the previous slide, when I was talking about the reactions to stress, that is kind of that at a biological level, that either that elevated baseline of cortisol, that not returning to homeostasis, that that overreaction, or that relative higher amount of cortisol, during that initial fight or flight response. So kind of those overreactions to minor stressful events, as measured by cortisol, has been found to predict adulthood anxiety and depressive disorders. So kind of, again, you don't have to get into the super biological weeds for the purpose of this class, but kind of the idea here is that overreactions, which you can measure at a biological level, but also at a behavioral level. If I lose my keys and I just start punching holes in the wall, kind of overreacting on a behavioral level. But you can measure those overreactions and the amount of hassles one experience, and then kind of like combine, and then see if those two things predict psychological disorders. And research has found that, again, number of hassles positive related, that is positively correlated, that is the number of as the number of hassles increases, the risk of depression also increases. Physical disease, mortality risk, defined as the chance that an individual will die within a certain period of time. A study of about 1,300 middle-aged adults called every day for 8 consecutive nights and asked about stressful events they experience and their reaction to them. Participants in a study who reported high numbers of daily stressors and negative reactions to those stressors were at higher risk of dying 20 years following the initial study than participants with lower numbers of daily stressors. The number of stressors reported contributes to the progression of heart disease, the risk of diabetes, and the onset of some cancers. Divorce, death of spouse, personal illness, job loss, death of a close friend, relative associated with a higher risk of breast cancer in a study of 10,000 Finnish women. Okay, so kind of quick overview here. We have the study of 1,300 middle-aged American adults. The researchers called these adults every day for 8 consecutive nights. And they asked them, okay, tell me about the stressful events that happened to you, and tell me about the level of reaction to those stressors tell me about your reaction to those stressors. And then so that data was collected, and then they what the researchers did was then look at kind of death certificates or health outcomes 20 years later. And what the researchers found was that the higher number of daily stressors one experiences and the amount of negative reactions, so the more negative reactions to a stressor, was associated with a higher risk of dying 20 years later following the completion of the original study. So exposure to the stressors and the amount of negative reaction to stressors being associated with risk of dying. And here we have and then the other study is the study of 10,000 Finnish women, which found that divorce, death of a spouse, personal illness, job loss, so kind of all these stressors of interpersonal within a person and economic stressors contributing to the increase of risk for heart disease and risk of diabetes. So kind of you can conceptualize this as just overall kind of that wear and tear on your body from stress hormones, but also again kind of possibly and probably unhealthy coping mechanisms. So dietary habits, but also increased levels of isolation, loneliness, for example, losing a close friend or spouse, or so isolation, depression, all kind of being intercorrelating and possibly contributing to these risks of diabetes and heart disease. The Finnish study also found that women who reported 1, 2, or 3 major or more major life events in the previous 5 years were significantly more likely to be diagnosed with breast cancer during the next 15 years than those who reported no major life events. The more events reported, the greater incidence of breast cancer. So this is kind of sometimes referred to as a dosage effect. Again, not tested on. Just the idea here is that the more of a dose, you can conceptualize this as a drug, the more of a drug you receive, the more X outcome is likely. Here, the more stress that a person experiences, in this case a woman, a Finnish woman experiences, the more at risk they are for breast cancer. Now, as kind of like a side note, again, not tested on, there is research that has found that stress prior to conception is also associated with kind of negative developmental outcomes in offspring. So even before a woman is pregnant, kind of stress, some researchers have found that like a year of stress prior to that, so you can just measure stress prior, a year's worth of stress prior to conception, and then again kind of calculate the total number of stressors experienced 1 year prior to conception and see if it's correlated with outcomes. And researchers found that it is. So maybe that there's a whole host of possible reasons. Maybe that immediate proximity to conception, maybe stress hormones impacting certain biological mechanisms within that abbreviated period of time, acting as a stress factor for certain offspring developmental outcomes. And another mechanism by which physical illness, diseases can occur from stress is the immune system. So our body's defense, immune system can be defined as our body's defense against invading bacteria, viruses, and other potentially illness-producing organisms and substances. Consists of the skin, lymphocytes such as T and B cells, and the macrophages, which is kind of a well, it's a type of white blood cell that targets kind of invasive disease-causing cells. Is kind of a simple version here. You don't need to get into like the weeds of those definitions, but kind of the idea here is we have this immune system, and it consists of these subcomponents. Psychoneuroimmunology is defined as the study of the relationship between the immune system and the central nervous system. It looks at how the brain reacts to the environments. For example, high levels of stress over the past year make you more susceptible to catching a cold virus. Deliberately exposed to a cold virus in a lab, unemployment, interpersonal difficulties, increase in hassles 4 days prior to exposure, network of friends/community protect against colds. One study found that caring for someone with Alzheimer's is associated with lower ability to heal from injury and decreased blood clotting. So the idea here is that the immune system can be weakened due to chronic exposure to stress. And even one study found that unemployment, kind of chronic interpersonal difficulties, and even in just an increase in hassles 4 days prior to exposure being associated with a higher likelihood of catching a cold virus in a laboratory setting. Now, interestingly, networks of friends and communities help buffer from the effects of colds. So again, suggesting that interpersonal support, that social support, that community support, those community macro factors, those protective factors, lessening the impact of stress on an individual, in this case on the negative effects of on their immune system. Similarly, stress and disease. A link has been shown between stress and heart disease. A study of 13,000 American men for 15 years these men were given physicals every 6 years. Death certificates were then examined 9 years after the completion of the study. The researchers found that work-related stress was associated with increased risk of death from heart disease. So the specific work-related stressors were being fired, being laid off, workplace injury. In another study, men at the highest risk for both cardiovascular disease and diabetes scored higher on their life change events questionnaires than those at low risk. So kind of similar to the other study, here we have 13,000 men, and the researchers found that the increased likelihood of heart disease being associated with work-related stress, that is being fired, laid off, workplace injury. And we've talked about in this chapter, but also previous chapters, that the impact of work has a large effect on your development. Again, as an adult, you spend a ton of hours at your job. And thus kind of the structure of your job, your rights at your job, the responsibilities, the autonomy, the level of control you have. The worker empowerment has an impact on developmental outcomes. And here, being fired, laid off, being associated with an increased risk of heart disease. And so it's not only that you just, you're going to lose a source of income, but also you can imagine someone working a job for X amount of years, decades maybe, and then they lose their job, and that's, they identify with that as that labor becomes a part of their identity that is then stripped from them. It's kind of society, it can be interpreted as society kind of smacking it in the face. So kind of a loss of social prestige. What is my place in the community? What did I just spend my life doing when I'm just kind of thrown to the side? I'm left here to fend for myself. So kind of that combination of losing income, losing kind of social prestige, standing in the world, purpose, then also contributing to, as we've talked about, spillover effects with interpersonal relationship issues, being at risk of increasing, and all those things kind of contributing to possibly, on a kind of a theoretical level here, the risk for heart disease. And specifically in this study, just being fired, laid off, and workplace injury being associated with heart disease. And interestingly, actually, on a side note, again, not tested on, there was a recent study that found that people who were most at risk of dying for COVID were, unsurprisingly, racial minorities, the poor in general, disabled individuals, and again speaking to that accumulation of stress, of disenfranchisement, of active violence against structural and personal, contributing to possibly kind of a just decreased immune system. And thus maybe putting them at higher risk of not just contracting the virus because they tend to work in more precarious jobs, but also dying from the illness itself. Not just because they're going to be less likely to have health care, but also because possibly this contribution of that accumulated wear and tear on the body being less likely to survive a novel virus. Mental health disorders. Stressful life events are associated with the onset of various mental health disorders. The same study that we just reviewed of 1.5 thousand men asked participants to report their daily overall moods. High levels of negativity in which they had, in contexts in which they had low to no stressors, were at risk of developing mood disorders 10 years after the study completed. One's reaction to stressors has an effect on who will develop a mental health disorder. PTSD, post-traumatic stress disorder, psychological response to trauma. Symptoms include re-experiencing events and intrusive thoughts / dreams, knowing of general responses, avoidance, increased arousal in physiological stress systems. Acute stress disorder, reactions to trauma similar to PTSD, but diminished typically within a month. 50% of PTSD cases begin with acute stress disorder. Interestingly, most long-term negative after effects are seen in people with pre-existing conditions and lifelong exposure to trauma. So, kind of as stated, we have that same study of 1.5 thousand men. They also asked, we saw that they collected data on the total number of stressors experienced every day, but they also collected data on their level of reactivity to the stressors. And this study found that higher levels of negativity, negative reactions in the context of low to no stressors was associated with mood disorder. So kind of, again, this general negative overview or stress that you experience, even in the presence of of limited stressors or no stressors, kind of that carryover effect occurring at a biological, but also at a behavioral level. So I'm overreacting to, I'm on edge, I'm stressed out through a life of stress, and even even in the context of just a kind of a minor inconvenience happening, or or no inconvenience is happening, I'm on edge. I'm at higher levels of negativity, and that's associated with, in this research, the study found that it was associated with a higher risk of developing a mental health disorder. Looking at PTSD, specifically in acute stress disorder, one interesting finding is some studies have found that the most long-term negative after effects of PTSD, symptoms associated with PTSD, being strongest in individuals with higher levels of exposure to trauma. So kind of putting them at risk, those people with, again, kind of higher elevated levels of exposure to trauma being at higher risk of developing PTSD or having the worst symptoms of PTSD. Treating PTSD, cognitive behavioral therapy, referred to as CBT, prolonged exposure therapy. 1/3 of people will show symptoms of PTSD within a week of traumatic event. About 10% will still show these symptoms a year later. Mental health problems due to stress can be passed down in families, possibly through an epigenetic process. Reparative adaptational impacts. Feeling job as a child was to fix the past and health of parents, more likely to develop psychological disorders. So a couple common methods of treating PTSD in the West is kind of exposure therapy, so kind of exposing people to kind of triggers so that through time, you're basically showing them the trigger, then saying, okay, so here's the presence of this thing that's really stressful to you, but also see how you just didn't die immediately by seeing this trigger. So you're kind of trying to desensitize that stimuli that's triggering to a person. And in cognitive behavioral therapy, the simplest way to think about this is kind of reframing the way you evaluate a stressor and kind of your reactions to it. It's cognitive based, it's cognitive behavioral. So kind of re-evaluating, so cognitive, how you react to things, so behavioral therapy. And then kind of as a sidebar, I'm getting interested in the impacts of trying to measure the likelihood of PTSD in different groups across the world. So like the idea here is exposure to war, mass violence, obviously, horrific. But it can meaning that, because we'll talk about it later on in this chapter, lecture, is the meaning that you assigned those kind of traumatic experiences. Do they kind of increase the risk of PTSD? So for example, were the Haitians in the early 1800s who overthrew the colonial regime of Britain, did they still have the same level of PTSD as a different theoretical unjust war? So what are these like liberatory movements that historically happened and still happen today? Is that associated? Is the exposure to kind of that level of violence alone associated with PTSD? So just unrelated, but kind of interesting things of how, kind of going back to previous chapters, that larger narrative, that personal story, that connection to a group or ideology impacting risk of PTSD. But here, for purposes of this class, you can see that only about 10% of people with PTSD show symptoms a year later. So kind of a limited, about 90% not, but still about 10%. Being still showing these symptoms a year later, and again kind of being associated with individuals who have high levels of accumulated stress, being associated with long-term effects of PTSD, and also this idea of reparative adaptational impacts. So kind of this feeling of as your job is to fix your parents basically, or your family, take kind of that load by yourself on and kind of constantly try and save the day kind of thing. This study found that was associated with a higher likelihood of developing psychological disorders. But also an important, and are kind of similar on that vein, and also it's important to understand different coping mechanisms across cultures. So beginning with social support, there's great cultural variation in coping and seeking support. Research has suggested that social support is good for one's health, regardless of cultural background, but the way people seek and provide social support may differ. So East Asians are less likely than white Americans to actively seek help from others. This is due to concerns about how this will disrupt relationships with others. Instead, they rely on implicit social support or finding emotional comfort in their close relationships, reminding themselves of the close relationships that they have. Whereas white Americans show less stress when they seek help, Asian Americans show less stress when they think about their relationships. Other examples include East Asians tend to offer problem-solving support more than emotional support. Russians also are more likely than North Americans to provide problem-focused support. Americans tend to provide emotional support involving positive feelings, whereas Germans focus more evenly on both positive and negative feelings. This may explain why East Asians tend to seek professional mental health treatment less than Westerners do. So the types of coping and social support sought are different across cultures. With one study here, one study reviewed, finding that East Asians relying more on implicit social support. So kind of finding support in the closeness of your inner group, your family, whatever your kind of inner circle is. So you can remind yourself of the closest that other people have, that you have with other people. Thus, you can maybe feel valued as a member of that community, that you're part of that group. And that kind of allows a person to understand that they have social support, but in a kind of a less direct way. It's implicit. And studies have found that when Asian Americans have a kind of a lower stress response, or kind of returning to that homeostasis when they think about their relationships. So kind of going back to the interdependent nature of some cultures, where the self is and what the self means, kind of being wrapped up in this in-group, and the value of conceptualizing yourself as part of that partially because that in-group means that you have a lot of social obligations to each other. So kind of having, recognizing those relationships kind of having a on average, kind of having a kind of qualitative difference, wherein you have a certain set of social obligations and responsibility to each other that is kind of collectively understood, and it can act as a source of social support. Also, East Asians focusing more on problem solving than emotional support. So kind of like, how do we, what is the solution to this issue kind of thing? And then interestingly, Americans on average focusing more on positive feelings. So, just gassing up your friend or whatever. Whereas Germans kind of emphasizing both positive and negative feelings. So, okay, yeah, it's kind of, I guess, in simplest terms of online speak, validating your negative feelings. So not just having, emphasizing the positive aspects of your life, but also kind of considering those negative feelings as well. So kind of a more holistic evaluation of feelings, kind of compared to Americans. And kind of building on that, to talk about psychotherapy and methods of support when faced with mental health disorders. So Western treatments traditions can be traced back to Freudian times. Freud thought that psychological problems were best treated by exploring people's memories and experiences, because such problems were believed to be rooted in people's conflicts and fears at an unconscious level. And the therapist should then interpret those experiences and memories. Carl Rogers then introduced the client-centered approach. Other kinds of psychotherapeutic approaches have since been developed as well. Cognitive behavioral therapy, which we talked about, involves restructuring unhealthy thoughts by identifying dysfunctional biases and alleviating negative reactions through controlled exposure. A common thread running through all the different therapy options is the client's ability to engage in a psychological discourse grounded in shared cultural meanings. There may be an implicit emphasis on understanding the individual, his or her self-discovery, and his or her cognitive biases. So kind of the big takeaway here is that these therapies that are developed and that's commonly talked about, because we live in the U.S., are rooted in kind of historical processes of the West, and certain understandings of development and certain understandings of the self. We talked about in previous lectures the idea of self-consistency, wherein you describe yourself, or where in that study that found that the Japanese university students describing themselves based on the Who I Am test differently depending on the setting in which they were at. So literally the self being defined differently depending on the environmental circumstances. We also saw in the Kenyan study with how people define themselves is different across cultures. With in that study, the Maasai Kenyans defining themselves, their personality characteristics or traits as were more likely, I should say, to define themselves in ways that represented their roles in the community and kind of social responsibilities, versus the American university students were more likely to define themselves as kind of possessing kind of unique qualities. So I'm smart, I'm tall, I'm whatever, I'm the best at playing video games, whatever along those lines. So kind of the idea here is that there may be a implicit bias within certain forms of treatment of mental health disorders, just based on that socio kind of cultural historical process in which these treatments develop out of, and also based on how people define themselves and imagine themselves and their role and how they imagine their life should play out. So is it so very kind of a Western idea here is it's kind of like you're on your own individual quest. You all have these innate abilities that are concrete and unmoving, no matter the circumstance. And your goal is to go through life and maximize that those kind of innate qualities, engage in that self-discovery process, which true or not, it contains certain ways of viewing the world. And it's also important to note in what context is that self-discovery occurring in? Is it just as the individual occurring? I'm on my own personal quest, or can I still engage in self-discovery and kind of self-fulfillment, but while also still kind of keeping in mind kind of these collective concerns? And so even those kind of universal self-discovery, possible notions of developing fulfillment of the self, still can be applied differently because different interpersonal and society factors are factored in. So maybe again, I've talked about this in other other chapters. So kind of the idea is self-discovery through your own personal quest. Or maybe is it self-discovery more likely or more intrinsically fulfilling, kind of in the context in which kind of this baseline kind of collective ethics occurs. So we talked about ethics in the previous class. So kind of the idea is that own personal fulfillment most likely and most rewarding on some human level in the context of upholding certain community ethics. And again, true or not true, different cultures have kind of different conceptualizations of that process. So one study examined indigenous healing practices used in 16 societies in Africa, Asia, South America, Middle East, and the Caribbean. 2 models of healing emerged in these places outside the West. One of the most common practices is the role of families. Family members were most important in resolving mental health problems. They shared the problems with the individual and were key source of guidance, especially elder members. They also shared the stigma and blame associated with whatever mental illness the individual has. Second, involves spiritualism and religion, which incorporates traditional healers such as shamans and sorcerers. Mental illness perceived as rooted in underlying spiritual problem or a relationship with God or gods that went awry. So the Yoruba in West Africa view the person as the union of body, mind, soul, and inner head, each of which comes into existence by specific gods. So this study found kind of 2 different models of healing emerging that's less common in the West, specifically kind of the role of the family. Again, kind of going back to the importance of that in-group family, and but also kind of these community elders, these nation elders, wherein they share the advice, the guidance, and those elders and that collection of people kind of feel sharing in the stigma and blame and responsibility for the development of mental illness. And we kind of cover this in our discussions with the removal of Native American cultural traditional practices, contributing to increased levels of alcoholism and risk of suicide, among many other things. So again, demonstrating the impact in these communities of these family members, elders, community in mental health outcomes. It's important to note that there's obviously kind of family therapy kind of things in the West, but it is far less common than psychotherapy approaches or kind of individual kind of behavioral techniques and exposure therapy in the West. Japan also has a couple of unique approaches to psychotherapy that reflect the cultural inclinations of Japan. Morita therapy and Naikan therapy. Morita therapy emphasizes secondary control, asking clients to accept the circumstances of their lives. Clients must change their perspective of the symptoms and learn to live productively in spite of those symptoms. Primarily used to treat depression and anxiety symptoms. To live productive lives, the treatment plan involves isolated bed rest, light manual activities, heavy manual labor, reading, and other forms of life training, all in combinations with meditation and therapy sessions. So here you can see kind of a little difference here of secondary control. So a more of acceptance of these things happen, they're not in your control. However, we can still live productively. We can change the perspectives of how we are interacting in this current world, the circumstances that we exist in. And so combining this combination of meditation, therapy sessions, while also kind of this interesting labor. So kind of this idea of being contributing to the collective good, finding your place back in the group, society, the world. Even going back to the Western examples of losing your job and the social prestige associated with that. So kind of this reimagining yourself, or maybe invigorating yourself, a reconnection with the world, kind of through labor, through reading, through meditation, training, therapy sessions, and while accepting certain unmovable aspects of the world. Again, kind of challenging kind of Western idea of you can change X, Y, the level of change possible in a single individual. Being different across cultures, and thus will be reflective in various cultural practices, in this case psychotherapy in Japan. Naikan therapy helps people gain insight on their past, used to treat people with depression and addiction problems. Clients are asked to reflect on their past, particularly on the kindness that they had received from others, while thinking about how little they have given in return for those kindnesses. Such as specifically thinking about close relationships with your mothers when they were a young child. Therapists encourages clients to appreciate how indebted they are to the kindness of important close people in their lives. Goal is to reinterpret the past, recognizing it cannot be changed. Revisiting the past through the lens of gratitude can restructure it and give new meaning to people's lives. So this is kind of similar to the kind of behavioral therapy where you're kind of conceptualizing stressors and reaction to it. But here you can see kind of a much more, a more direct, an explicit tie-in to your historical legacy, your heritage, your culture, your in-group, your family, your closest to your mother, your other extended relatives, your elders. And thus kind of imagining all that kind of the collective sacrifice that they did for you. And obviously as a kid, you could not repay them. Now it's kind of your opportunity to kind of contribute to that larger good. Recognizing that whatever those elders or family members, whatever, may not have been the best, but it cannot be changed, and kind of reinterpreting it in a sense of gratitude, and again trying to reconnect people back into this kind of historical legacy and heritage, which is conceptualized as an opportunity to give meaning, give a narrative back to that person's life. Given cultural differences in prevalence rates and culturally specific presentations of mental disorders, matching treatments to the culture seems crucial. One concern that has been raised is whether Western mental health treatments may sometimes do more harm than good. It's been argued that anorexia did not exist in the same form in Hong Kong until it was imported there. Post-traumatic stress disorder was not a big problem in Sri Lanka after the 2004 tsunami until Western aid workers insisted they must be suffering it. So this is a kind of a classic issue, and that is covered heavily in the kind of stress research, wherein kind of Western aid workers or Western therapists going to X context and separating an individual from their family and putting them in a room and saying, okay, now you have to talk to me and we're going to get to the bottom of this yourself. So really kind of actually removing people from sources of social support and kind of interrupting those indigenous, whatever that countries, that nations, that cultures, natural kind of coping process is, kind of interrupting that process that people are brought up in their entire lives, and then moving them to this other coping process, thus stressing them out and contributing to higher risk of developing certain mental health disorders such as PTSD. And I already kind of alluded to me grappling with this abstract notion of post-traumatic stress disorder in the context of like liberation. But you can also see it in natural disasters such as tsunami, wherein this study, some researchers argue that Westerners kind of aid workers insisting that these people must have PTSD, increase the prevalence of PTSD within these Sri Lankans. So maybe for whatever reason, in that context, PTSD was non-existent or very low, relatively low, and for various interpretations of that event. However, kind of applying kind of a specific diagnostic form of mental health disorders developed in the West, and we've talked about the DSM in previous chapters, possibly, again, kind of increasing the risk of PTSD. All right, let's jump ahead. Individual differences in stress-related disorders. A majority of people handle stress well. The type of stress and the amount of stress makes a difference. Other factors in stress reactions include gender, age, racial discrimination, and environment, gene interactions. So kind of, I've already talked about, alluding to that dosage effect, that accumulated amount of stressors, so the type of stress exposed, and the amount of stress, how long that stress is present within a community or to a person, within a family, impacts the effect of stress. And looking at gender, women report more daily stressors than men. Women and men report different sources of stress. On average, men report more stressors related to work, school, women interpersonal in a 2005 study. I would suspect that to be different now, honestly, but it was in the book, so I included it. Men are exposed to more trauma than women in their lifetimes, but women are more likely to experience PTSD as a result of trauma. Women are more likely to experience rape. However, men's risk of PTSD when experiencing rape is higher than women. Men's more likely to be physically assaulted. However, women's risk of PTSD is higher when being physically assaulted. So kind of walking through this, looking at a few key points here, the differences in different sources of stress. I say it might be different now because women's participation in the labor force is significantly higher than it was almost 20 years ago. So I would suspect that more work-related stressors increasing in women since 2005. And then the kind of final few points here is that really the interpretation and the expectation of a stressor occurring to you can have an impact. So in the case of men's likelihood of being raped, they can maybe think, oh, that's impossible, it can't happen to me, or whatever. So kind of that expectation of there is no way that it can ever happen to men, for example. Maybe that can contribute to an interpretation wherein that severe violation of expectations may be placing them at higher risk of PTSD. Maybe, and then kind of see that vice versa with men, maybe thinking, oh, I have a high likelihood of being attacked by some other guy, therefore being physically assaulted, not great, doesn't feel great, but maybe having a less violation of some moral trust because they expect to be, or they are more likely to be expected to be physically assaulted than women. Again, this is all kind of theoretical possibilities, but kind of the takeaway here is that different genders at different historical moments can have different reactions to specific stressors. Discrimination. Minority groups suffer overt discrimination in the workplace education, the justice system, and healthcare systems contributes to worse life outcomes and more stress than those in majority groups. I should say a higher risk of worse developmental outcomes. Perceived discrimination, when an individual realizes or believes themselves to be the target of discrimination, linked to increased stress and unhealthy behaviors. One meta-analysis found that perceived discrimination from sexual orientation, mental illness, physical disability, HIV status, and weight was most strongly predictive adulthood well-being. Discrimination associated with lower levels of recall, gait speed, I should say, elevated systolic blood pressure, cardiovascular disease, and drug abuse. And we've talked about this throughout the course. Minority groups being a higher likelihood of being exposed to kind of greater levels of disenfranchisement, greater levels of adversity within their developmental context, which puts them at greater risk of negative developmental outcomes. And specifically, we've had this one meta-analysis finding that these various forms of disability statuses being associated with adult well-being, kind of suggesting that kind of the presence of overt and kind of more subtle discrimination across all factors: society, education, workplace, various healthcare systems, accumulating again in negative developmental outcomes, in this case here, adulthood well-being. We also, I've already alluded to the recent finding that poor individuals, racial minorities, disabled individuals being at a higher risk of dying from COVID. And interestingly, discrimination being associated with all these other risk factors: cardiovascular disease, recall, gait speed, drug abuse, again speaking to one, the intercorrelation of all these different factors. So we talked about discrimination or lack of kind of positive developmental opportunities being associated with kind of decreased memory, in this case here memory, but also physical development, so gait speed and cardiovascular disease. So all of these things kind of just in a context basically of widespread discrimination, disenfranchisement, individuals are exposed to more stressors, kind of less, they have less protective factors, and less kind of opportunities to engage in healthy lifestyle behaviors, healthy eating, exercise, reading, etc. And thus kind of can, thus that cocktail of development contributing to increased risk for all these various negative developmental outcomes. And I want to highlight this one study that kind of speaks to this. It's really kind of this is sometimes referred to as double jeopardy, but also intersectional identity. So looking at Muslim women who wear hijabs in the workplace, and so kind of this combination of social class, job stress, job satisfactions among Muslim American women. Looking at 129 Muslim women, and the results revealed that workplace discrimination, job stress, social class, and religiosity were related to lower levels of job satisfaction. So kind of the idea here is that that combination of discrimination increasing to lower levels of job satisfaction. Now, interestingly, again, not tested on, there is a study that found that following 9/11, on September 11th, Muslim women across the United States were at higher risk of giving birth to a child with lower birth weight. This is thought to be because kind of elevated levels of discrimination against Muslim Americans, especially during that time. It really concentrated. Levels of hate crime went up significantly. Discrimination just went up very significantly. And basically what they found was, and I think it was in California, that, so literally the opposite side of the country, Muslim women having a higher risk of giving a birth to a child with low birth weight. So again, kind of a really good example of kind of this these various groups that individuals belong to, those various identities, In the case of Muslim women, possibly wearing a hijab, you can imagine them also being a racial minority. All those kind of risk factors contributing to, in this case here, lower levels of job satisfaction, but also in that study that I reviewed, a higher risk of giving birth to a child with low birth weight. And low birth weight children, if you don't know, it's kind of associated with various negative developmental outcomes across their lifespan. There are ways to correct that trajectory, but in the case of poor Muslim women, for example, they're going to have less opportunities to, less resources to kind of help kind of correct that developmental trajectory in their offspring. Income inequality. Subjective perceptions of wealth can act as a stressor and are predictive of adult health outcomes. In other words, the subjective experience of feeling poor can matter as much as being poor. A sense of relative deprivation, knowing others are doing better than you, may lead to stress and negative health consequences. There is something to be said about the health benefits of having some money in general, such as the countries that are on the left side of the scatter plot. Allows people to have access to life-sustaining cultural practices such as medication, but beyond a certain level, about 30,000 annual per capita, objective wealth does not predict life expectancy well. This is particularly problematic in societies where there is a great social inequality. The relationship between a country's Gini index, which is one measure of the amount of income inequality within a country, and life expectancy is strongly negative. R equals negative 0.8. So here we have this subjective interpretation of a stressor. So you can imagine, being a relatively poor and looking around you and seeing, okay, other people have more money than me. So, and then kind of being in the context of this, just talking from the U.S. perspective, being in the context of like a meritocracy, wherein the idea is that everybody is sorted according to their abilities, the best rise to the top, and that's sorted through kind of educational experiences, people with the college degrees having the most credentials, and thus having justified place in our society. They earn that position. I am in a different position. I make less money, so therefore so I guess it's my fault. I am the reason why this happened to me. I know that I can see around me that other people are doing better than me. Thus, that's going to contribute to my stress. I have failed in some way. You can imagine that we talked about developmental trajectories being off schedule, for example, when an event occurs. Here that can be involved as well. But that I personally, on my own individual quest for self-fulfillment, has failed. And that can be incredibly stressful. I've wasted my life. I screwed up in some way. Now, interestingly, though, that income inequality has been found to be associated with average life expectancy across countries. And it's a strong negative correlation. Again, this strong negative correlation means that the higher, in this case here, the higher the income inequality, the lower the average life expectancy. And negative 0.8 is a very strong effect. 1 is a perfect correlation, which is not possible. But negative 0.8 is a very strong finding in this study. So it's kind of speaking to, and this can speak to various things. So kind of access to healthcare and healthcare programs within the country, which is kind of a lack of healthcare practices or healthcare services within a country, kind of being associated with lower average life expectancies within the country. So kind of in the absence of those really protective buffers against stress, an individual is kind of more on their own. Maybe they take on more medical debt, and that also operates as a stressor, which can stress you out, but also maybe put you in neighborhoods that are more unstable, which is again another source of stress, less healthy food, etc. So you can see how all these things are kind of like a domino effect. Wherein income inequality decreases protective factors, which increases the risk of dying earlier. All right, moving on to some genetics, environment-gene interactions. Expressions of our genes can be influenced by the external conditions we experience. Differences in genetic expressions believed to be more impacted by developmental heritage or development environment than heritage. Human social genomics, the study of changes in gene expression due to subjective perceptions of the social environment. A 2007 study collected data on 2 groups, a group of socially integrated people and a group of socially isolated people. Participants who were socially integrated showed more activity in anti-inflammatory genes and less activity in pro-inflammatory genes. Isolated individuals showed less activity in anti-inflammatory gene activity and more activity in pro-inflammatory activity. It suggests that it suggests that social experiences can alter genes. This effect has been found in working class individuals as well. So kind of the idea here is that we have two groups: socially isolated, socially integrated. Socially isolated will lack those protective factors of social integration, of family, of social support. And here, the socially isolated individuals were more likely to show more pro-inflammatory genetic activity, and inflammation in general is kind of associated with kind of a biological breakdown, or just an increased risk of chronic illnesses and increased risk of kind of early death. So social circumstances here, in this case social isolated, thought to be activating or being associated with genes that produce inflammatory kind of activity at a biological level. And interestingly, this has been found in working class individuals. So kind of the exposure to being poor, lower class, having higher levels of pro-inflammatory genetic activity. It's associated with, because rooted in the fact that they're exposed to the vast amount of accumulated stressors and have lower levels of social support, and going back to this specific example, more likely to be socially isolated. Stress-related growth. Stress-related growth is positive changes that follow the experience of stressful life events. Growth seems most likely when distress is significant, but not completely crushing. Opportunities for growth after a salient stressor if personal beliefs and social support are available. Short-term, more minor stressors can contribute to growth, necessary part of development. And we've talked about this, alluded to this throughout this course, but the idea that all stress is bad, all stress is equal, any amount of stress is bad is not correct. And as a stress researcher, I often question myself, has this new emphasis on stress and trauma is actually negative to understanding the human condition? I debate that all the time. But nevertheless, so kind of the idea here is that some stress is good for you. So dropping off your kid at kindergarten the first time, they're going to cry the first day. Guess what? A month from now, they're probably going to get over it. Bearing the fact that, whatever, the kindergarten isn't abusive, and, whatever, the standard caveats. Or teaching kids to swim, they might cry or whatever, but they'll learn to swim. It's going to be all right. So kind of the idea here is that these short-term, kind of minor stressors are necessary to growth across the lifespan, not just children, but in adults as well. Coping with stress, resistant resources, personal and social, community, national resources that may buffer a person from the impact of stress. The book proposes 4 categories of coping: problem, emotion, meaning, and social coping, social focused coping. Problem focused coping, directly addressing the problem, causing distress, ability to do something to reduce the impact of stress or prevent it from happening. Spam calling your company until they fix the issue. So kind of the idea is directly engage with the issue, especially when you can actually do something about it. So whatever, your internet is acting up, so you're just spam calling like whatever your internet company is until they actually fix the internet. So just directly addressing the problem at hand is kind of the idea of problem-focused coping. So kind of straightforward. Emotion-focused coping, ways people try to decrease the negative emotions associated with a stressful situation. Alcohol and substance-related abuse is a form of emotion-focused coping. Distancing can be good or bad. It depends. Social abuse is related to stress levels for college students. A study of response patterns after DC sniper incidents. Emotional focused coping, such as medication, disconnecting, blaming government. No gender differences in these ways of coping. So kind of the idea here is that you're trying to decrease your negative emotions associated with a stressful situation. You can do this through a variety of ways, taking medication, or drinking, drug abuse, whatever, smoking weed, whatever, I don't know. And then the idea here is basically that at times, Those specific alcohol abuse, for example, it can be a negative developmental outcome to dealing or negative way to emotionally cope with someone. Distancing can also be a good or bad thing. So creating distance between you and the stressor that can make you isolated, but at the same time, sometimes you just have to get away from a stressor. So it really depends on the circumstances of how positive that emotional coping mechanism is. Interestingly, in response patterns to a DC sniper incident, you can just Google it. It was there was a sniper in the DC, kind of straightforward. And this study found that some of the emotional focus coping techniques was medication, disconnecting, and blaming the government. So here you have some medication, so kind of using medication kind of to deal with the negative emotions associated with the incident. Disconnecting, so I'm just checking out. I'm not dealing. I'm out. I'm taken to the woods. Not really, but kind of disconnecting from kind of that story. And then blaming the government. So kind of saying like, oh, it's this entity that I can't control. It's their fault. It's not on me. That kind of helps kind of make sense of that stressor and kind of situate yourself as where you fit within kind of this larger narrative of responsibility and kind of who the victims are, basically, in that scenario. Meaning-focused coping, ways that people find to manage the meaning of a stressful situation, reframing a stressful situation to focus on the positive or beneficial outcomes. Didn't get into the best graduate school, but you didn't really like research that much anyway. Can be helpful in chronic stress situations, as caregiving. So kind of just find meaning in a stressful situation. So one way to do this, as stated, is kind of reframing it, a stressful situation based on the beneficial outcomes. So you apply to some colleges, whatever, you apply for Harvard or whatever, and you don't get in, and you're like, you know what, that would have cost me $200,000. So, oh well, I guess it's kind of good that I didn't get it. Or whatever, you're watching this right now for some reason, and you have an F. I wouldn't be watching this if I have an F in this class, but maybe you're just like, hey, I'm just gonna watch these lectures, and you're like, you know what? Screw this. This class sucked anyway. I hate psychology. I'm going to take a different class. So kind of so reframing it, and then because I'm taking a new class, I can take a new class that I actually like, or with a professor who's good. So kind of the idea here is that reframing the stressful situation to look into the positive or beneficial outcomes associated with the presence of that stressor. Social focused coping, seeking help from others, the actual affirmation and aid received from others, perception one is cared for, and social support is available if needed. Loneliness is associated with higher risk of physical, psychological disorders, and death. Buffering, which I've alluded to throughout this class, lessens impact of effects of stress on a person. Social support in a high stress situation may serve as a buffer against later stress reactions. Study of 89 gay males found that discrimination increased stress. However, persons with strong social support reported lower levels of negative affect. So here, kind of straightforward, you're seeking social support, you're receiving help, you're receiving affirmation, or kind of the perception that someone cares about you and that help is available if needed. So even if you don't want help at this moment, but kind of the idea that, oh, if I ever need it, then I have someone that I can depend on. And relatedly, loneliness, as we talked about, and kind of isolation being a risk factor for physiological or psychological and physical disorders and death. In a study of 89 gay males, measuring kind of the amount of stress they experience, the amount of discrimination they experience on a daily basis, gay males who had reported higher levels of social support the study found that gay males from the top. This study found that of the 89 gay males, among those 89 gay males, those who had the highest amount of social support were at the lowest risk of negative affects, so kind of that negative daily mood. So it suggests that social support kind of decreasing the likelihood of having that baseline of negativity kind of every day, because it gives you kind of an outlet, and it also gives you kind of a sense that, oh wait, yeah, I am being discriminated against, but also I am supportive, I have social support available, and people care about me. Skipping ahead, negative social relationships. Studies of Black Americans and Black Caribbean families have found that positive family support is associated with lower rates of depression, Chronic negative family interactions are associated with higher rates of depression, however. A study of homeless people found that shedding burdensome abusive relationships are associated with positive developmental outcomes. So kind of straightforward here. It says, yes, social support can be good. Having that inner circle can be great. However, if your inner circle or family support is negative, it can have a negative impact on you. So chronic negative family interactions being associated with higher rates of depression in this study of Black Americans, Black Caribbean families. Also, a study of homeless people found that leaving those social dynamics of abusive, burdensome relationships being associated with positive developmental outcomes. So, kind of that. So, social support, family support is great, is positive when it's positive, but also can result in negative developmental outcomes when it is negative. Evaluating the overall effects of coping argued that if you feel in control of a situation, problem-focused coping is likely the most effective method. In situations where one feels out of control, emotion-focused coping might be more helpful. Flexible coping, ability to adjust coping strategies as the situation demands. It's critical to continue with many stressful situations. There's a time and place for everything. So just like I said before, sometimes distancing is good. Sometimes, frankly, having a beer, you're gonna be all right. Okay, you're gonna live. It's not gonna be that unhealthy for you. It's gonna be all right. So understanding that time and place for everything, being flexible though is kind of associated with the positive developmental outcome. So recognizing kind of your constraints in that specific environment and recognizing how to either A, just survive through it, or B, kind of make the best of a good situation and then see like, how once I'm out of this situation, how do I improve moving forward so I'm not in as challenging circumstances? What can I depend on to kind of decrease my kind of negative daily mood? So kind of that flexibility basically is kind of the argument here. Resilience. Defined as the ability to maintain healthy functioning following exposure to potential trauma. Resilience is the most common long-term outcome, not recovery or PTSD. Intervention is important for those who have sustained or developed extreme levels of chronic stress, but current practices of giving all individuals exposed to trauma psychological treatment may undermine natural resiliency. Research shows beyond basic necessities, information and support / reuniting social units, not helpful and may increase risk of developing PTSD, get in the way of natural recovering processes / strategies, intrusive, undermine community self-efficacy. All right, so resilience, again, can be an entire class. So what is resilience? Who knows? Well, whatever. There's a debate on what resilience actually is. And the idea here is if resilience is the most common long-term outcome, then it's just normative, and what's kind of the point and why it's so hyped up, because that's just the normal response. So instead of looking at the majority of the population, maybe you should look at people who don't demonstrate resilience, or people who are on the other end of like the distribution of resilience, who are just like resilient with everything. So kind of understanding what is resilience, why are you measuring the total population? Is it a personality trait? Is it a community trait? Very debated, even though people just use the term flippantly. And I've already kind of alluded to the final points here, but kind of the idea here is that just universal mass, one size fits all psychological treatment in the presence of trauma can actually undermine natural resiliency. Because as stated, most people are just going to not develop PTSD, for example, like 90% of people. And especially in across cultures, forcing certain treatments can undermine natural resiliency practices, because again, it's kind of the norm, resiliency, and get in the way of natural recovery processes, and in fact, kind of undermine them. So kind of how do you go about, what is resilience? How do you develop resilience in a community and a person? And what that actually means is very debated, and it informs kind of public policy. How do you Haiti gets hurt with an earthquake? What do you specifically do about that? If actually anybody cares, what do you do about that? That's kind of partially rooted in your understanding of what resilience is. Control and resilience. People at high levels of perceived control are less apt to suffer physical and mental health problems as a result of stress exposure. perceived control, belief that one can experience his or her circumstances and attain his or her goals. The most traumatic events, the more traumatic events participants reported at middle age predicted risk of early death for those who had low sense of perceived control. So kind of the idea here is that is these source of traumatic events, is it from something that I control? Is it something that I can either remedy moving forward, or something that's kind of resulted in my own actions, something that's with, again, kind of adjustable, or is it just something that's beyond my control? The world is operating in a way that I can't imagine, or it doesn't even matter if I imagine, because I can't shift these larger systems that are just beyond my control. And in this study of U.S. middle-aged adults found that the risk of early death was associated, or an increased risk of early death was associated with low sense of perceived control. Now, interestingly, the poorer you are, the less likely you are to feel that you are in control, which kind of makes sense because you are literally not in control of the world around you. So this could be it could be covariate for statistical hits, or intercorrelated factors, wherein the people who feel like they're most in control are the people who do have actually slightly more control of their daily lives. But also kind of in general, if you feel that you can shape the world through yourself, or kind of through some collective unit, you feel like you're more likely to be at risk for these long-term negative developmental outcomes, in this case, early death. And I want to wrap it up with a couple examples, and I'll just look at the one on the right here. And this is actually a study from one of my very good friends in UF. She looked at black teenagers in high poverty neighborhoods in Alabama, and what she found that she created a cumulative risk factor that combined effects of the past year's exposure, so basically the amount of exposure of racial discrimination, stressful life events, exposure to violence. And she found that cumulative risk was associated with negative developmental outcomes. But interestingly, she found that the cumulative risk with internalizing problems was buffered by adolescents' religiosity and neighborhood collective efficacy. The association between cumulative risk with externalizing problems was buffered by parental monitoring and collective efficacy, protective factors to buffer effects. So basically what she found was that these community resources, this collective community sense of, hey, we can develop our community, we have some kind of control of our community, and then, like I said, community resources, so kind of access. She was looking at, I believe, like access to gyms and parks and libraries, stuff like that. At buffering, reducing the impacts of being exposed to these cumulative risk factors, and these are very severe risk factors, exposure to gun violence, for example. But she also found it at a parental level, so parental monitoring, reducing the impact of stress. So sometimes that kind of a more strict parenting style can be beneficial to a child, especially in an unstable developmental context. All right, so with that said, that's all for this chapter. Thanks so much for listening. Bye. Have a great week.